Good evening, all. Welcome to the new session that is GB pathologies. We will try to see some few interesting cases of GB gallbladder. So, coming to the first case, here you can see there are multiple echogenic foci noted in the gallbladder with adjacent GB wall thickening and even pericholecystic free fluid. So, this was a case of acute calculus cholecystitis. And here you can see this is the other case where you can see there are echogenic lesions noted projecting from the wall of the gallbladder projecting into the lumen of the gallbladder. So these are gallbladder wall polyps. So common differential can be impacted GB wall calculi. These here also you can the other case here you can see there are linear echogenic structures noted within the GB lumen. So this was a case of GB worms and this was a case of biliary ascariasis. So these are the common GB pathologies we will encounter in routine ultrasound practice. Here also you can see there is echogenic sludge noted in the GB, and the echotexture of the GB is similar to the echotexture of the liver. So this is called as hepatization of the gallbladder. Hepatization of the gallbladder due to echogenic sludge. Here also you can see there is mass-like sludge balls noted within the GB, and they are attached to the GB wall. However, these are mobile and there is no associated GB wall thickening. And also on color Doppler, you can see there is no raised vascularity because these tubifactive sludge mimics the GB wall GB malignancies. So these are few differentiating points which helps in differentiating tubifactive sludge from gallbladder wall malignancies or gallbladder malignancies. So these will be mobile, they will be attached to the wall, there will not be any other wall thickening or breach in the wall with pericholecystic extension, and also on color Doppler there will not be any vascularity. So this is tumefactive GB sludge. Here you can see these are the other multiple echogenic calculi with sludge. So this is lithogenic sludge. So hepatization of the gallbladder, tumefactive GB sludge and lithogenic sludge. Next, here you can see there is a diffuse thickening of the GB wall and there are multiple small cystic diverticular-like structure noted within the thickened wall. So these are multiple intramural cystic diverticulae. This case is a classical case of GB wall adenomyomatosis. So this is GB wall adenomyomatosis. Next, here you can see there is diffuse calcification of the GB wall. So this was a case of porcelain gallbladder. Here you can see there are multiple varices or collaterals noted adjacent to the GB and even extending into the peripancreatic location. So these are multiple GB varices. Here you can see there are GB wall is thickened, but there are multiple small cystic hypoechoic nodules noted within the wall. So this picture, whenever you see the GB wall is thickened with multiple intramural hypoechoic nodular lesions which may be varying from 5 to 20 mm, so definitely suspect xanthogranulomatous cholecystitis. And most of the times you will also be able to see calculi within it. Here also you can see this is a GB and there is thickening of the wall with adjacent breach and adjacent collection. So this was a case of gangrenous cholecystitis with perforation. Here also you can see there is GB which is herniating through the defect in the right lateral abdominal wall along with the bowel loops. So this was a case of GB herniation. So already I have covered this case in multiple hernias. Next, here you can see there is a stone which is impacted in the distal small bowel and there is multiple dilated small bowel loops. So this was a case of Gallstone ileus. Next, here you can see there is diffuse calcification of the gallbladder wall. So this was a case of porcelain gallbladder, which is a pre-malignant condition. Here you can see there is free air noted within the GB wall. Can you see the free air noted within the GB wall? Here also you can see there is a free air which is noted within the GB wall. So these are cases of emphysematous cholecystitis. So first one is Gallstone ileus, second one is porcelain gallbladder, third one is emphysematous cholecystitis. Next, here you can see this is the GB wall. GB, there is a breach noted within the fundus of the GB and there is adjacent pericholecystic collection in the fundal region. So this is a case of sealed off GB perforation. Here also you can see there is the GB, there is perforation of the GB. So this is other case of GB perforation. Here you can see there is GB wall, there is multiple GB wall thickening and even free air noted within the GB with even catheter insertion. So this was a case of emphysematous cholecystitis with rupture and catheter insertion. Here this also you can see there are multiple GB calculi and also you can see there is breach noted within the right lateral wall with adjacent collection and also there is spillage of the calculi into the peritoneal cavity. So this was a case of GB calculi with cholecystitis and even adjacent perforation and spillage of the calculi into the peritoneal cavity. So these are the different varied pictures of perforations which can be presented in practice. So remember all these. So there can be focal sealed of GB perforation. There is GB perforation along with emphysematous cholecystitis GB perforation, and also GB perforation with spillage of calculi into the peritoneal cavity. We will try to see few fetal cases. Here you can see this is the echogenic sludge in the fetal GB, which may mimic, sometimes may mimic echogenic bowel. Next, here you can see there is a small sludge ball noted within the fetal GB. This is the stomach, you can see. This is the fetal GB with small sludge ball. Here you can see there are two GBs, that is called duplicated GB, and there is no vascularity on color Doppler. So this differentiates them from vessels. So this is duplicated fetal GB. Next, here you can see these are the miscellaneous cases. Here you can see there are multiple membranes, sloughed off membranes within the GB along with GB wall thickening. Here you can see after giving contrast there is vicarious excretion of intravenous contrast via liver into the gallbladder. So after giving contrast, the contrast has excreted from the liver into the gallbladder, which is called as vicarious excretion. Here you can see there is a diverticulum arising from the right lateral wall of the GB. So this is called nothing but a case of GB wall diverticulum. Next, here these are the few cases of GB wall adenomyomatosis we have already discussed. So this is focal fundal GB wall adenomyomatosis. Here these are the multiple diverticulae, that is the diverticulae within the wall. Here you can see these are the cholesterol crystals which are lodged inside the diverticulae, which gives this post-acoustic enhancement, and this type of shadows, that is a comatella reverberation type of artifacts which are due to cholesterol crystals which are lodged inside the Rokitansky of sinuses. Here also you can see there are a GB wall with multiple intramural cystic diverticulae, and when there is a diffuse focal GB wall adenomyomatosis, this gives the pearl necklace appearance on MRI. So these are the different various presentations of GB wall adenomyomatosis. So this was a case of focal fundal GB adenomyomatosis. This is diffuse GB wall adenomyomatosis and pearl necklace sign on MRI. Next, here also these are the few cases of Gallstone ileus. Here you can see there is pneumobilia, that dilated small bowel loops with stone lodged in distal small bowel. Here also you can see there is GB with air foci and even stone noted lodged inside the small bowel, that is ileum, and there are dilated small bowel loops. Here also you can see there's a GB with sludge and the stone is lodged inside in the distal small bowel with dilated small bowel loops. So these are varied presentations of Gallstone ileus. Next, here you can see there is a mass lesion which is arising from the fundus of the GB, and there is raised vascular and color Doppler. Here there is a mass lesion completely replacing the GB with infiltration into the liver and also into the stomach and in the duodenum. Here also this is a coronal section with diffuse GB wall thickening. So these are varied cases, different cases of GB malignancy. Here this is a case of porcelain gallbladder, and also you can see there is a soft tissue density mass which is seen extending into the cystic duct and even into the common hepatic duct with IHBRT. So this was a case of porcelain gallbladder with soft tissue mass in the neck region extending into the common hepatic duct, turned out to be adenocarcinoma. Thank you all.